Heart disease and stroke remain among the leading causes of death in Guyana, with doctors now warning of a worrying rise in sudden deaths among younger adults in their 20s, 30s, and 40s, often occurring during sleep or routine activity. These cases are linked to undiagnosed heart disease, uncontrolled hypertension, diabetes, high cholesterol, and lifestyle risks, increasingly seen among younger people. This week on Sources, Dr. Mahendra Carpen, one of Ghana's leading cardiologists, who also served as the head of internal medicine and cardiology at the Georgetown Public Hospital Corporation, examined what is driving this trend, the warning signs the public must not ignore, and how cardiac care in Guyana is evolving. Welcome to Sources. I'm your host, Svetlana Marshall. This evening, we'll be talking about cardiac care and the growing concerns surrounding heart disease. Joining us tonight is Dr. Mahendra Carpen, widely regarded as one of Ghana's leading cardiologists. He also served as the head of internal medicine and cardiology at the Georgetown Public Hospital Corporation and has been very instrumental in advancing modern cardiac services here in Guyana, including interventional cardiology and cardiac electrophysiology. Dr. Carpen, welcome to Sources.
Well, thank you very much, Svetlana. It's been something in the making for a while for us to have this conversation. And I'm very happy that we're having this opportunity to do so now.
And thank you so much. I know that you have a very busy schedule, but thank you for fitting us in. Dr. Carpen, tell us a little about yourself. You've been, you graduated, I learned, since 1997, so you've been around for quite some time.
You're going to age me. Now, I'm a native of Guyana, born and raised in Berbice. Luckily, in 1985, I was part of the first batch of students to attend President's College. Having graduated from President's College, I did University of Guyana for medical school. And subsequently, I maintained my luck. I was able to go to Jamaica to specialize in internal medicine, and Canada for cardiology, adult cardiology, and interventional cardiology. And then on to Boston, USA for cardiac electrophysiology. I came back to Guyana in the end of 2012, November 5th actually, and I was operating on November 6th when I came back. And I've been associated with the Georgetown Public Hospital, the Caribbean Heart Institute, and later as I got myself more settled, I came out in more of the private sector, as well as maintaining a public sector presence. I was at Woodlands Hospital, Mercy Hospital. And one of the things I actually enjoy is to help build programs, and I have been fortunate to do so in our sister Caribbean territories. I had been working in Trinidad and Tobago at St. Clair Medical Center for 2 years. I used to go over there every month, do some work. I did some of that same thing in Jamaica. And currently I am a visiting cardiologist in Tortola, British Virgin Island, where I do cardiology, interventional cardiology, and things within my specialty.
Why cardiology though? What led you to that, to study cardiology in the first place?
Well, I knew from very early that I wanted to be a doctor, but you didn't know exactly what part of medicine I wanted to get into. But at every stage, like life, every step of the ladder, you can see a little bit further. And as I finished high school and I went into medical school, the people who I met as tutors and teachers in medical school were able to point me along the way. And one of my greater influences was Dr. Ramsundar Dubey, widely regarded as the father of internal medicine in this country. And myself and practically all of the current graduates have had interactions either with Dr. Dubey as a tutor or people he would have trained. And so I knew then that I wanted to do internal medicine. And so I went to Jamaica to specialize in internal medicine. When I was there, I met another Guyanese, Professor Charles Denbo, who's an internationally renowned cardiologist who was head of the internal medicine and cardiology at the time at Mona. And he basically impressed me and guided me along the way to get into the programs in Canada, etc. And at every stage, something else became clearer until 12 years overseas. I decided it was time to come back home. I would have done a full circle, spending some time in the Bahamas as well as clinical tutor for internal medicine at UWI campus there. So coming home for me was a little bit delayed, 12 years out, but I'm happy that I made that choice. And even though moving back to Guyana, having lived overseas for a while, can always be a challenge, but having overcome a lot of those challenges, there's no place I'd rather be.
Glad to hear. And you're doing an excellent job providing advice at the highest level, at the level of the Office of the President, at the level of the Georgetown Public Hospital, and in your private capacity. So we would want to thank you as you continue to provide human service to the people of Guyana and across the region. Now, after nearly 3 decades, next year is going to be 30 years since you've graduated, and dealing with medicine, like you said, you've trained abroad. How do you see the overall state of cardiovascular health in Guyana?
Well, there's an experience that I always go back to sharing when talking about this. As a medical student in the early days of practicing medicine in Guyana, something as simple as an ECG, which is an electrocardiogram, the basic cardiac test, we used to see maybe 1 or 2 per week. Fast forward to where we are today, we're about 100 per day just at Georgetown Hospital.
Wow.
So we've moved. There was a time when if you had a heart attack, you would just have to take medicine, rest, relax, and hope that you were going to get better. Now, and those who were fortunate at the time could have gone overseas and gotten treatment, angiogram, and stent. Last year, we were able to do over 850 angiograms with stenting and all of that stuff for heart attack patients at the Georgetown Hospital. So we moved from a rather rudimentary level in that time to where we are now, where essentially patients in the public sector can access all of the care from walking into the emergency room with a heart attack, heart failure, or slow heart rate, people needing bypass surgery, people needing pacemakers, etc. And all of that can be provided free to public patients at the Georgetown Public Hospital. So it's been a remarkable transformation over the last 30 years in cardiovascular medicine. But that's not just for cardiovascular medicine, that growth and progress. It's all across the health sector in this country. There was a time when dialysis was not easily available. It was very scarce. At Georgetown Hospital, we used to experiment with peritoneal dialysis. Now there are so many dialysis centers across the country Now, we're able to treat conditions, and we have to now go back to the basics of preventing things from getting to that stage where we need advanced care. Even in the best circumstances, however, all across the world, the countries with the best outcomes still have a significant percentage of their population getting to the complicated stages of disease processes that requires stent, bypass surgery, dialysis, transplants, etc. What is unique is that because of their robust primary health care and prevention, their people tend to require that service a little bit later in life. We in Guyana and the Caribbean, because of our gaps in primary health care, tend to not recognize risks early, tend to not recognize problems early, and therefore we can't intervene. Simple things like lifestyle. There's a time that the heart attack patients coming into Georgetown Hospital, 1 in 3 or 30% of them didn't know they had diabetes. The first time they're finding out they have diabetes is when they came to the hospital with a heart attack. And we did the test and say, hey, are you diabetic? No, doc, I'm not diabetic. Well, your blood sugar is 280 or 300. And that's when they find out. And diabetes is a major risk factor for this in our population in particular. So as we move forward with the advanced stuff, we have to always remember to take care of the basic things, early screening, testing, and therefore we're able to intervene earlier to prevent these issues. We may still get all of the problems, but perhaps we can push back the onset 10 years, 15 years. So instead of having these serious problems when you're 30 and 40, it could go to 60 and 70.
Okay. And we'll talk more about that as we go along with the program. Now let's look at what the WHO said. The WHO data show that heart disease and stroke remain among the leading causes of death in Guyana, accounting for approximately 87 and 71 deaths per 100,000 people, respectively. That's in the case of heart disease and stroke. What does this tell us about the health of the nation?
So all across Latin America and the Caribbean, this is an issue.
Yeah.
Unfortunately, that's one of the distinctions we don't want to have. We like to be all of the other things that are good. But it comes back again to a couple of things. Primary health care, but there's also a recognizable risk inherent in persons of our genetic and ethnic makeup. Let me break that down a little bit. Persons of South Asian descent, a lot of our population is of Indian origin, have smaller coronary arteries. That's the arteries around the heart that supply blood and therefore take oxygen to the heart muscle. So they're starting out with a smaller artery. Then you have a different pattern of cholesterol. There are certain small cholesterol particles that are not measured in the standard cholesterol profile, for example. And those seem to be of higher prevalence, the bad ones and the good ones of lower prevalence in persons of South Asian descent. And diabetes is also something that is higher. Whether it's related to the specific type of diet for that population, we're not quite sure, but diet does have a role to play. Then the other major segment of our population, persons of African descent, tend to have higher blood pressure issues, tend to have more kidney issues, tend to have higher incidence of stroke. So we're a nation blessed with many things. Unfortunately, we also have higher incidence of disease processes.
Why so?
A lot of it is genetics and some of it is lifestyle. But recognizing that means that we have to actually take steps earlier, which is why I'm particularly pleased with some of the programs that we have embarked on recently. A recent collaboration between the government of Guyana and Mount Sinai Hospital has started screening program for our children at primary school and secondary school. I believe the latest reports show that we would have covered in all 10 regions about 90+% of all primary school kids. And that's remarkable because here it is from very early. You can look at these kids, you can see what their weight is, what their nutrition is like, what their eyesight is like, what their dental health is like, everything, mental health, everything. So these kids are screened, and thankfully we're able to explain this enough to parents that they understand that this is something that will benefit this population for generations to come. Now imagine at primary school level, you identify certain risk factors that you know can be problematic. You're not quite sure what they can do. Fast forward 10, 15, 20 years. The pace at which medicine is moving, if there is a disease process or a risk factor that's identified in primary school, by the time we get to 10, 15, 20 years in the future, there's likely to be cures and things we can do to help treat a lot of the things that we're picking up now. As things as advanced as genetic modifications, you can alter people's genes, you can use stem cell therapy, etc. While those things are novel therapies now, in 10, 15, 20 years, the data that we collect now with our young kids can be used to let them live longer, happier, and healthier. In the primary school, we have had success in screening. We started a little bit later in the secondary school, but we're approaching 50%. And as we are continuing this program, we're hoping that we'll have the same level of success with the secondary school kids as well. So this is something that we recognize we have to take action for, and thankfully the government of Guyana has started this process.
Since the screening has commenced, have you been able to, say, for example, detect maybe heart diseases in the younger children, and how many would have reached like the stage of getting the treatment they require and the different types of diseases you're seeing, heart-related diseases?
Right. So particularly or specific to heart disease, what we are finding or what we can look for at the young age is a risk factor for heart disease. Other than that is if these children are born with certain heart conditions, things like hole in the heart, abnormal connections of the major blood vessels, etc. Now those kids generally, once they are born in a hospital or health center, they're picked up at that level. The school program is a little bit different. Now children with heart disease, right now the Georgetown Hospital is really the only place that can offer definitive treatment, surgery, etc. And this is in collaboration with a number of overseas partners that come in periodically and do like 15, 20 surgeries at one time. And the impressive thing about that, some of these experts that come from all over the world, a number of them are actually Guyanese living and making tremendous contributions around the world in children and heart disease.
Mm-hmm. Earlier reference to lifestyle choices and how we live, how we eat, whether we exercise or not. Let's talk about that and the impacts of or the effects of not doing or living a healthy life.
Yeah, so this is something that is very important. And as Guyana gets more hectic and as we're always on the drive and we're hungry for success and advancement in our careers, in our financial planning, etc., one of the things that people sacrifice a lot is a healthy lifestyle. So you get out of the house earlier than usual. There's not enough time to prepare home meals. You get on the road, you get fast food. You get home late because you're working long hours, so something unhealthy again for dinner. And there's no time for exercise. There's no time for relaxation. There's no time for stress relief. That's a major issue when we come to cardiovascular disease. When we talk about lifestyle, we're basically talking about things like what you eat, what your activity is like, and what your social habits are. We're looking essentially for a lifestyle that can merge all of these healthy habits. When we look at diet, for example, what we want to do is to reduce the consumption of carbohydrates. We want to reduce the consumption of fats and improve proteins, vegetables, and fiber in our diet. And I always counsel my patients, if you imagine a plate that is round, half of that plate should be vegetables, whether it's steamed or raw, salad, whatever. The other half, you divide in two. One portion for protein and one portion for starch. And that's a basic healthy plate. So diet is very critical in maintaining a healthy lifestyle. When it comes to exercise, the American Heart Association and all of the cardiovascular authorities in the world would recommend that persons have 30 minutes a day, 5 days a week of cardiovascular exercise, or 150 minutes per week. 30 minutes a day, 5 days a week. What does that entail? Brisk walking, cycling, swimming, playing sports. A lot of people like play football, basketball, cricket, etc. Just get active enough to break a sweat. And that goes a very far way. Not only is it important for cardiovascular health, but it contributes to the pleasures of life. It contributes to weight management. People are more comfortable with themselves. People are more productive at home. It makes for healthier relationships. It makes for more productivity at work. And of course, if you're healthier, you're spending less on healthcare as an individual and as a country. Then habits that we have that can sometimes prove to be detrimental to our health. Things like smoking. And I want to pause here for a moment and talk about vaping. Vaping is a particularly bad recent development in our country. Vaping can have sometimes even worse immediate side effects than tobacco smoking. Why? Because a lot of the chemicals contained in the vape can cause a couple of things. They can cause your heart to race. They can cause the blood vessels to spasm. And when that happens, it raises your blood pressure, and it can actually cause heart attacks by causing spasms of the coronary artery. Recently, we've seen data being published about lung disease related to vaping that are irreversible and incurable. And this is one of the things we would like to have our young people know. To stop vaping, do not start it. If you haven't started it, and if you are doing it, to please stop it. The other thing that it does is that on the inside of the blood vessel, it causes inflammation. Now, inflammation can damage the lining of the blood vessels, whether it's in the brain, in the heart, the legs, the stomach, etc. Now, when that inner lining is inflamed and it's damaged, the body tries to repair it. It tries to repair it by forming clots to cover up that damage. Unfortunately, that repair process is disorganized and it doesn't know when to stop healing. So that clot can keep forming and getting bigger and bigger until it blocks up the whole blood vessel. And that's when people get strokes, heart attacks, etc. So that's my little opinion
Very
on
important,
the
because
vaping
that is like
practice.
a big trendy thing that is happening that we ought to guard against. Have you seen at the local hospitals persons coming forward with these either lung or heart disease as a result of vaping? Have we seen those numbers coming in?
So what I can tell you is my own personal experience, and this is backed up by my colleagues as well in the field. When I first came back to Guyana, the average age of the heart attack patients were in the 50s and 60s. And we hardly saw anybody younger than that. Now it's routine to see people in their late 20s, 30s, early 40s with severe heart disease coming to the hospital. Some of them, especially young women, seem to not be able to tolerate smoking and vaping at all. And so that's a particularly vulnerable group. Women with smoking, women with vaping, it's not cool, not good for health. That's very dangerous.
Earlier this year, you spoke about this very thing. You said, you notice people in their 20s, 30s, 40s coming forward, increasing. You address the issue of sudden deaths. Why was it important at that point to make this public appeal? Like, what exactly we're seeing on the ground?
Yeah, so, some of this is almost a disbelief with the number of sudden death or what is attributed to sudden death in our society that has just been flooding the media, social media, online. You can see these things happening, and these are young people in their most productive years with young children, in the midst of building a career and a life, etc. And unfortunately, again, health is something that can creep up on you, and then suddenly there is a change for the worse. And so these are things that we want to bring public awareness to, that you have to get yourself checked out early. Look for the things that are known to cause problems. Make sure the blood pressure is controlled. A lot of our people don't want to take medications because they think, oh, this is just me and this is normal for me. No, high blood pressure is not normal. Or, I ate something this morning, that's why my blood sugar is high. Well, there's certain tests that we can do to check for diabetes. It doesn't matter what you ate today or last night. It checks the average of your blood sugar for the last 3 months. So, and it's called the HbA1c. So the HbA1c, I think is greater than 6.5 in most labs would be considered a problem. You can't come and say, well, your HbA1c is 9 and that's because you ate something last night. No, it's been bad for the last 3 months and this is the average. So these are things that our people have to pay attention to. And then get yourself screened for the weight, the cholesterol levels, check the kidneys, check the urine, see if you're spilling proteins in the urine. All of those things are important parts of cardiovascular screening. And when done early, and if there's a problem, then you could actually address it earlier to prolong life, and not only just prolong life, but maintain good quality of life.
Mm-hmm. You spoke about the importance of getting checked. Do you see more? It is believed that more women come forward and get health checks done when compared to men. Have you seen increasing numbers of men coming forward? And like you rightfully said, some people say, you know what? I don't need to go to the hospital. I could use some remedy, maybe it's nothing important. It's just a headache, it's just your pain in the eye or something of the sort. Like, what are you seeing with regards to the number of men coming forward and the dangers of, diagnosing yourself?
Yeah, so the availability of information online is a two-edged sword. A lot of times it, helps people tremendously and can answer questions, that otherwise you would have left unanswered. But sometimes we have a habit of reassuring ourselves falsely when we see something online. You want to believe things are good so badly that you ignore the red flags. Now, back to the earlier part of your statement, the Caribbean man in general is one of the hardest demographic to go and seek preventive care. Caribbean men in general wait until there's something wrong. I believe there's a belief that to go and get medical help is a sign of weakness, etc. But it's not. And so that's a cultural battle that we've been fighting with over the years. Women are more likely to seek help when something is not right and admit that, I need to get this checked out. So that really is our biggest issue. And I have been seeing a few people who otherwise would not have come to get checked out, they have been, making an effort to get themselves screened, at least in our practice at Georgetown Hospital as well as in my private practice. And some of the health centers are reporting the same thing too. And that's what we want to encourage people to do. You see, in the last 2 or 3 years or so, the government of Guyana Ministry of Health has actually recognized that we need to do more in screening. And there are several programs available, and I'll draw your attention to the main ones that we have, the universal health screening vouchers that we have. I encourage everyone to make sure that you collect your vouchers to go and get yourself checked out. All of the primary things that you can do, including your blood tests, your cholesterol, and all that stuff, is included. And you can actually go to a private lab. You don't have to line up at a public hospital, or you don't have to step foot into a public hospital. These are things that are covered in a way that it caters to the convenience of people. So in those kind of things, you have to take advantage of what's available. Other voucher programs are available to look after your eyes as well, spectacle vouchers, and in particular for cancer screening, there are things that we have available for prostate cancer screening as well as cervical cancer screening.
Earlier you spoke about, sometimes these things creep up. Is it a case that it is creeping up on people, or we're just ignoring it? And then, pops, the next day you're dead. Like, what's happening here? So, he was a healthy person, or she was a healthy woman, and then all of a sudden she died. And for persons who will live, is there a difference between cardiac death and heart attack? Like, what's the difference?
Yeah, so we'll talk about that. The thing about creeping up, I think it's a lot of times there are warnings, but we misinterpret what these warnings mean. And the biggest pet peeve I have when it comes to my cardiac patients is when they complain about gas. Walking up the step and I just gas pain, and I had to stop and drink some tea, and then I start feeling better. No, there's no such thing as exertional gas. If you're getting pain while exerting yourself, climbing step, walking faster, or trying to jog or whatever, that's not gas, that's something else. So a lot of times we misinterpret that, and then you stop, drink the hot tea, and you think you feel better. You feel better because you stopped exerting yourself, not because of what you put in your mouth, right? So that is an important thing for us to recognize.
What are the other warning signs that we oftentimes ignore?
Shortness of breath. Things that you used to do normally, you can't now complete the task without getting short of breath or feeling winded. You used to walk, 4 blocks to get to work or whatever, or go to the shop, and now you gotta rest, you gotta walk slower, you can't get there as fast as possible. So those are, easy fatigability, shortness of breath on exertion, chest discomfort on exertion. When we, long ago when we were in medical school, they used to tell you that the classic symptoms of blockage or heart attack, etc., is tightness in the middle of your chest. You feel like an elephant sitting on it. That is now a minority of cases. The majority of our patients have what we call atypical chest pain. It's a discomfort. It's something that they can't quite describe. A feeling of fullness, a burning, and it comes on when they try to do stuff. So it's not the typical textbook description anymore where there's an elephant sitting on my chest, it comes up to the neck and go down my arm and the jaw, etc. No, it's anything in the adult population, and I always tell my students and the doctors on the training, if it's bothering these patients with risk factors and it's from the navel to the chin, think cardiac first before, because that's the one that would actually kill you. Now you asked about a heart attack versus a sudden death. Now, sudden cardiac death has been described more in relation to an abnormal heart rhythm that leads to mechanical dysfunction. So the heart is controlled by electrical activity, and that dictates how the heart pumps. When that electrical activity is in disarray, when it's not coordinated, the muscle of the heart cannot pump. And when it can't pump, then there's no blood coming out, nothing goes to the brain. And if there's no blood and oxygen going to the brain, people start to feel dizzy and then blackout, fall down. The vast majority of time when that happens, unfortunately, people do not make it. Even in the best places in the world, this, what is called sudden cardiac death, 5 to 10% of the people survive. The best places, New York, London, Toronto. And only a very small percentage of those people actually make it into hospital in time to have something done. You've seen TV shows or movies where people are rushed to the ER, and they put paddles on their chest and say, clear, zap. And then miraculously they either recover or they don't after several zaps. That's the sudden cardiac death. Now, blockage and heart attack is different. Blockage, if you think of typical or the traditional sudden cardiac death as an electrical issue, blockage is a plumbing issue where the artery of the heart is blocked, and so therefore blood cannot pass, and oxygen, which is carried by the blood, cannot pass. It can't reach the tissue of the heart. So therefore, the tissue become compromised because oxygen is needed for the cells of the heart to survive and to function. So when that happens, then they start to misbehave, and then they could actually go into abnormal rhythm because the oxygen controls how much energy the cells produce, and that controls electrical activity, the contraction, etc.
Okay.
So
You identified blocked arteries, uncontrolled hypertension. You spoke about that earlier, infections, enlarged heart, and inherited conditions. Now, these conditions are becoming more common among younger people. And you spoke a bit about that, but I want you to elaborate because clearly we need to emphasize and to get the message across, because more and more we're seeing young people struggling with diabetes, they need dialysis, they have heart disease and all the other list of conditions they're having. So what needs to be done? What needs to be done? How could we, you spoke about inactivity and how we should exercise more, but what more could be done? That's the question. What more could be done? And the danger is,
how many cars are coming in the country? How often?
Gordon say about 10,000.
Yes. So, and they're coming in more and more affordable. People with jobs can afford to buy vehicles for the large part, or somebody within the household. And if not today, then they could see a plan where they could actually afford vehicles. So you're driving from point A to point B. We no longer observe bus stops. So even if you take public transportation, people want to be dropped off on spot in front of the place that they're going. They're not going to stop at a bus stop that's 150 meters, 200 meters away and then walk. So our physical activity as a people is reducing dramatically. Then what I alluded to, what we eat earlier. A lot of the stuff that we eat, particularly fried foods, what that does, it has a pro-inflammatory effect on our bodies. It raises the inflammation in the total body from head to toe. And when that happens, inflammation can damage blood vessels. It damages the vessels around the heart, vessels in the brain, vessels in the kidney, etc. And if you perpetuate that over time, it could actually cause significant, what we call target organ damage. The target organs are like the brain, the heart, the kidneys, etc. So our diet has a role to play in it. There was a time when traditionally almost a lot of our people had a kitchen garden. Used to grow something, used to eat something. We used to eat more vegetables, ground provision, all of that stuff. Now it's a completely different dietary makeup that we're, or dietary culture that we have.
And so it would not, eating healthier would, it will not only address like heart disease, but it'll address things like diabetes, which is
All
also a
kinds of
contra,
stuff.
high cholesterol, like you said, all hypertension. So it's important for us to eat healthier. Now, we've identified the issue, right? We spoke about some of the things that we could do as an individual. Let's talk about what you spoke about, the vouchers and so on, and that's an excellent initiative. Persons could go and do the medical checkups. But let's talk about the services. And you've worked at the Georgetown Public Hospital for an extensive period and led the department there. When you look back, how has the hospital and the services evolved over the years? Let's talk about that.
So the Georgetown Hospital is a typical example of a evolutionary success story where, you know, we started out, in my experience, with, for example, one doctor as the only internal medicine specialist in Georgetown Hospital for a number of years. We have now moved to a point where we are training our own internal medicine specialists at Georgetown Hospital. We're producing 4 to 6 every year. Not just Guyanese, but we're training persons from the Caribbean as well, that we can supply that need. See, we have had to come to the realization that our destinies are in our own hands. And if we want to get where we're supposed to go, we have to take certain proactive steps. So we train internal medicine specialists at Georgetown Hospital, so we have a lot more now. When you have more human resource, you can do a lot more for your patients. We have moved now from not having any advanced imaging. We have CT scanners at Georgetown Hospital. We're now going to put in MRI machines. We're doing mammograms. We're doing all kinds of advanced imaging studies. In the cardiac section, we've moved from having to send over patients overseas for advanced care to doing bypass surgery, valve surgery, etc. at Georgetown Hospital. In neurosurgery, we never had a neurosurgeon here that can, supply our needs. Now we have a program that's training neurosurgeons. We have fully trained and qualified neurosurgeons on staff, general surgeons, gastroenterologists. So all of the specialties, nephrologists, we have a robust dialysis program that's not just at Georgetown Hospital, but across the country.
But I was going to ask you about that because, during the course of the interview, I've spoken about, the Georgetown Hospital, it's a primary hospital in the country. But our persons say, for example, in the hinterland, in some of the rural areas, are they able to access some of these services? Would they be able to go and get some of the treatment there as against traveling all the way to the city?
So that's an excellent question and an excellent topic for discussion, because we in our country have unique challenges and unique opportunities to overcome those challenges. The geography and the population spread in our country dictates a lot of what we are able to do. So for example, if you have a remote village with 200 persons, it's not always appropriate to have a major hospital to serve 200 people. One, you wouldn't have the staff, and the volume of the work to be done will not be sufficient to allow the staff to maintain competence, because this is a practice. That's why you call it medical practice. You get better with more practice. Nobody starts out excellent. You will get better with experience, right? So the systems that we have put in place keeps evolving. And what I'm particularly pleased about, we're using technology now to be able to provide services to those who are not, for example, in the major population centers of Georgetown, West Coast, New Amsterdam, etc. So I don't know if you saw it in the news. Most recently, we actually had drones delivering medications to our remote villages.
Just this past week.
Yeah.
Yeah.
And so that's the beginning. There's a proof of concept. We now know it can work. We can do this. So yeah, that's what we're going to do. Instead of, having people to take hours with boats and planes, etc., to take in simple things, we can do that, delivering care.
And that is one of the major issues, the ability to deliver the
Yeah.
medical supplies on time. Because I remember years ago going to Region 7 in Middle Mads, and the issue is that by the time they get the medication, it's either expired or it's months past. And so I think with this technology now, they'll be able to get it on time. So that's a big move.
Yeah.
How person reacted to telemedicine? Are persons receptive? For example, those in the hinterland, are they happier? Are they utilizing the services now, or are they still insisting? Because you have people who would insist, I have to come to town and see the doctor.
Well, again, that's a cultural thing, and maybe I myself might feel more comfortable with a human interaction.
Yeah.
Stuff. But let me tell you a little bit about how our telemedicine program works. The telemedicine is not in isolation of on-site healthcare provider. So let's say we have a remote village. There's a health center, there's a community health worker, a nurse, a medics there, and there's a patient that they need an opinion from a specialist from. That community health worker goes online and speaks directly to the specialist in Georgetown or wherever that specialist is. And they're able to have one-on-one communication, opinions, etc., on how to manage these patients. And if there are pictures that are necessary to be taken and then sent over, videos, etc., counseling, whatever interventions can be done, and the triage process works. So if you need to send the patient out, or if the recommendation is, hey, look, I don't think you guys can manage that, send them to us, that's done. So if you notice how, I don't know if a lot of people have spent time to study this, but where all of the regional hospitals that we have built recently, where they are, it serves as the concept of the hub and spoke model for healthcare, where there's a central advanced center, and then all of the outlying clinics and smaller facilities serve as the spoke. So the big hospitals, the regional hospitals, are the hubs, and then they have a further hub, which is the Georgetown Public Hospital, which is the final referral center for the country. So all of the regional hospitals are strategically located in major population or catchment areas, so that people within a certain radius of those locations can have access within 1 to 2 hours of those bigger hospitals. Then if they need to be moved on to Georgetown Hospital or another facility, then we have that system in place. And coordinating all of that now is a rollout of the National Emergency Management Services, which will have ambulances and other emergency equipment and interventions available throughout the length and breadth of the country where our population are. So that, it's an interesting and exciting time for us as a country to watch this development move from where we were 30 years ago to where we are today and where we're going.
And as we celebrated our 60th independence anniversary in May, we conducted what was considered the world's longest distance robotic cardiac telesurgery from Guyana to India. Tell me more about that. You were part of the team. Tell me about that initiative.
Yeah, so like everything else in medicine, this took a team, a fully committed, dedicated team led by His Excellency President Ali, Minister Frank Anthony, and the entire Ministry of Health, Georgetown Hospital management structure, and doctors. So this first telesurgery, the record-breaking one, just for simplicity's sake, the doctor and the primary robot were in Georgetown Hospital. The patient and the secondary robot were in an operating room in India. So whatever, it's like a telephone call, whatever we were doing here, whatever the surgeon was doing here, was transmitted to the robot in India that was operating on the patient who was in India. It was a demonstration of what is possible with good teamwork, coordination, and actually it's a very proud moment for Guyana to demonstrate what we can do despite where we're coming from. But this is an announcement for the next era in our history. So that was the first case. Then we moved to, so that's tele-robotic surgery, where the patient and the doctors are in two different locations. That was, I think, 20,000 kilometers, and it was the longest recorded distance between patient and doctor for telesurgery in the world.
And the surgery was successfully done?
Patient and was successfully discharged afterwards, and several weeks later, we haven't heard any issues, right? And the patient is in India.
You're telling me about the other surgeries?
The other surgeries that happened were robotic surgery with the patient and the surgeon on site. What we were able to do is to close a hole in the heart for a young man. He was born with a hole in the heart, and he got into his early adulthood, and not suitable for the usual pediatric type closure through the leg. He needed surgery. Traditionally, this is done by open chest surgery, where you cut down the middle of the chest, open out. So that has its own recovery issues, risks, etc. It's a more invasive surgery. So the robotic surgery is minimally invasive. So they put some tubes, like the size of your pen, between the rib spaces to actually look into the heart, and look into the chest, identified where the hole is in the heart, and then patched it right there.
And some might
And
ask,
the patient is home 3 days later.
some might ask though, can't we have like humans doing that? Like, can we do it manually without the aid of a robot? Like,
So the robot is operated by a human. It's just precision, and robot is not tired. Robot. So the fantastic thing about it is that if I'm looking in, I can see what my glasses tell me. The way the robotic system is designed, once the camera is in the body, is a 360 view, and you could see it projected on the big screen, magnified, and with 3D glasses. It's like you were the surgeon is in the human body, and you can see front, back, side, up, down, all dimensions.
Wow.
So the precision is remarkable. And the proof is in the pudding, as you say. The patient went home 3, maybe 4 days later. Ordinarily it would have been 7 or 8 days. We saved 4 days of cardiac ICU stay, which translates into cost. And subsequent to that, we have had other surgeries. The team, that local team, has been performing robotic surgery on site with good success. We haven't had any major complications, and we expect that process will continue, because again, medical practice, you have to keep doing it to become experts at it.
How do you see like your patients do for these type of surgeries?
Yeah, there are particular criteria. Obviously patients have to consent to be a part of any surgery. Robotic is something new that we've introduced in Guyana, so the patients have to consent to have to be operated on through this process. But it's not as if they're not in contact with the surgeons, the nurses, the anesthetists. Everybody is around. But instead of being over the patient, they're on the console doing the surgery.
I understand that. Would this help with backlog of cases? And do you have a backlog of cases in like the country or at Georgetown Public Hospital, and how this would help? I heard the Prime Minister of Trinidad, Barbados, when we had the ceremony, talking about this historic surgery done, talking about how we could assist other Caribbean nations like Barbados. Yeah,
so I think that would be our phase 2, where we're now branching out from Guyana to assist in our other sister territories. And we're actually very excited and committed to having that done in the future. at the Georgetown Hospital, in the public sector in general, there's always going to be a little bit of backlog for certain cases because, disease processes keep happening, people keep living longer, etc. And the more doctors you have, the more you're able to recognize things earlier. And the more you say, well, you need to have this fixed. Now that we have been training our own people, our own surgeons, our own doctors, more people are out there in health centers. They can recognize things earlier. They can send patients for interventions, etc. So there's always going to be a backlog in any public system around the world. But luckily, as you get better using the robot, this would be able to minimize hospital time, minimize complications, and improve long-term outcomes for these patients.
Dr. Carpen, given that cardiovascular disease remains responsible for roughly 1/3 of all deaths in Guyana, what gives you hope that maybe the next decade there will be better outcomes?
So a couple of things would contribute to better outcomes. Some are patient dependent, some are professional dependent. So patients, we expect, will become more knowledgeable about their conditions, more knowledgeable about health. We expect that people will adopt healthier lifestyle, exercise, diet, not pick up bad habits like smoking, vaping, etc. Getting themselves checked out to get early screenings, diabetes, hypertension, cholesterol issues, all of the things that you can do to minimize your risk. And as medicine advances, perhaps there will come a time where cure and more definitive treatment for the conditions that plague us now, those interventions can become more and more accessible and available. So you see, a lot of things can be done, but it's not always accessible for everyone. And as we develop as a nation, part of the challenge of policymakers is not just to have things available, but accessible. And comes back to what we talk about, our brothers and sisters in the hinterland areas and the remote areas. So the more that we advance in Georgetown, the more that we take on new challenges. The challenges of our policymakers is, and they've been working at this all the time, is to make things more accessible and equitable for all Guyanese, regardless of all of the factors that seem to put us in different boxes: age, gender, religion, location, ethnicity, sexual orientation, all of those things that really ought not to be barriers to equitable healthcare.
Dr. Carpen, closing remarks.
Well, I'm very fortunate to be witnessing this phase of Guyana's development and being in a position to compare it to what existed before to where we are now. And I'm grateful that we have people in our system, colleagues, professionals, leadership that are able to see the vision and take us to that next level where equitable health care is available for all and accessible to all our Guyanese brothers and sisters.
Thank you so much for speaking with me. And I want to take this opportunity to wish you happy Father's Day. Yes.
Thank you.
Yeah, so the program is aired on Father's Day. So happy Father's Day to all our fathers out there. And to our viewers, thanks for watching. Use the opportunity. Dr. Carpen spoke about the health vouchers that are available at the Ministry of Health. You could get them at Ministry of Health in Brickdam, at the regular health centers,
hospitals, etc.
Hospitals. So go utilize those vouchers, do your health checks, and ensure that you live a healthy life. We want to live longer, right? That's the objective. And so thank you so much. It has been a pleasure. And join us again next week for another edition of Sources. I've been your host, Svetlana Marshall.